Welcome back, everybody. We had a great past hour discussing the strategies around virtual health, virtual care, and where people should be investing their time and energy into specific areas. But we wanted to pick up the topic and make it a little bit more grounded in reality, realizing that all the benefits of the virtual care that we're providing, the hybrid care that we're moving towards, is not equally being distributed. And of course, everybody knows that there is inequality in almost all parts of our lives, but unfortunately, when you do inequality in healthcare, it's more meaningful because it can be easily seen that there are entire pockets of populations that are not doing as well from a healthcare perspective as other pockets are that might be in wealthier areas. So this discussion is going to be all about health equity, accessibility of healthcare, not the same thing as access only, but there are lots of potential patients that we're leaving behind. It could be the deaf, it could be the blind, it could be people with more dyslexic conditions, autistic conditions. There's a lot of people that accidentally get left behind, not because we're doing something wrong, but we're not paying attention to them. So health equity, accessibility, patient access are things that we're going to talk about here. And then trying to produce a healthcare system that is truly universal is really, really difficult. And that's why we've assembled a really great set of panelists here who are dealing with this day to day on the ground. So I'm going to let each one of our panelists, as usual, introduce themselves. We're going to start off with Jan. We're going to go to Ray, and then start off with Nabil. And then we'll begin by asking some questions around what Nabil and Ray are doing in their particular environments. And then Jan will help comment on that as well. Jan, go ahead.
Sure, thanks, Saeed. I'm Jan Reed from T-Base Communications. What we do at T-Base is everything accessible. So we're working in all digital, so markets of your websites, digital portals, all of those sorts of things, as well as print, which is braille, large print, reprint, and even some audio. So definitely looking forward to this panel. Love it. Thank you.
That's fantastic. And I love what T-Base does here because so accessibility as a requirement is there from the federal government perspective. So, every website, et cetera, must be accessible on the federal side. Unfortunately, those laws do not always apply equally to commercial or other non-federal sectors. But this discussion hopefully will let people understand it's really important. It doesn't matter whether it's a federal requirement or not. If your patients can't read all the beautiful stuff that you've got on the screen, that's a problem, right? So there are ways of solving that, and companies like T-Base and especially Jan and her crew do that for you. So definitely reach out to them. With that, Ray, tell us a little bit about yourself.
Yeah, good morning. My name is Ray Lowe, and I'm the Senior Vice President and Chief Information Officer here at Ultimate Health Services in Los Angeles, California. We are one of the largest federally qualified healthcare centers, community clinics, in the country. We serve over 300,000 lives in Los Angeles, Orange County. Many of those are primarily Latino, multi-ethnic, and they are the essential workers that have been so heavily impacted by the COVID crisis, where we have had episodic gaps in care and high mortality rates. And we are so honored that our mission is to advocate for social justice and bring that delivery of care into these most essential markets. So thank you for including us.
No, that's fantastic. And what I love about what Ray and the crew do out there in Southern California is they're living this day to day. This is not, it's not a small group of people on the side that maybe don't have access. Literally all the patients that you work with. And I've been in love with FQACs for many, many years, primarily because it's one of the few organizations in which patient representation is mandated at the leadership level. And I just wish there are more organizations that do that, because you want your patients to truly have a voice, and you can't get a better voice than actual position in board and in leadership. So thanks for everything you guys are doing out in California. Nabil.
Hi, everybody. My name is Nabil Shahari. I am the Chief Clinical Transformation Officer at Metro Health. Metro Health is one of the largest safety net hospitals. We're in Cleveland, Ohio. We also, like Ray, serve about 300,000 plus unique patients that we take responsibility for. And very similar to Ray, we serve a lot of the underserved. We about 40 to 50% of our patient population are Medicaid, or what we call also self-pay or uninsured. So with that said, I am also a practicing physician. I'm a urologist, so I would like to bring in the provider side of the equation and how we look at health equity, social determinant of health, and clinical transformation all at the same time.
Yeah, that's
And I'm glad to be here.
Yeah, perfect, Nabil. So, and of course, you're heading up your clinical transformation area there, and it's really great that you have such a high percentage as well of the underserved that you're dealing with. So it's not one of those side projects for you where you're trying to improve access or improve a little bit of care on the side. You have to do it as a core part of what you do. Let me start off with the first question to all of you. Maybe we'll start off with Nabil. As part of your clinical transformation role, do you feel that if you could handle proper care transformation, care delivery, care coordination for the underserved, that actually makes the care for the wealthy, the normal kinds of other patients that you have better? Or does it take your eye off the ball and kind of like if you work with the underserved a lot, does that make other parts of your healthcare worse? Any thoughts?
Oh, absolutely. It shouldn't make the other part of the work any.
That's what I was hoping to hear.
So I mean, it's a little bit silly in a way. It's the one. There's a reason why they are underserved. So we need to pay a little bit more attention to them. We really need to understand what their needs are, how they want to receive care, where do they want to receive care, and which modality we're going to need to provide care. We have most in this country solved to the equation to the other camp, and we are really at this point in time trying to serve and try to solve to the equation to the camp you just described. So I think one does not really remove attention from the other.
Great.
They complement each other, to be all honest, because if you're really able to divert that, not to divert, to provide, I don't want to call it divert, because I was just going to fall in the trap that you set me up. If you are going to provide the right attention to those that we need a little bit more of the non-traditional care that is provided in the health system, addressing their social determinant of health needs, etc. Actually, it free you up to do the other stuff as well. So it's not one or the other. Everybody wins out of that situation.
Perfect. And I think that's a great way of putting it. And I wanted to give a provocative question to start off with, because people feel like that's the case is, I have to divert attention or I need to do something separate over here. The way we should really think about it, and I saw Ray, you nodding a lot, so I'd like for you to comment on the following. If you buy this argument that for decades, the quote rich countries have been spending a lot of money in R&D, drugs, medical devices, et cetera. So a lot of the inventions came from the need of patients, but often paid for by those who could afford to do the R&D and things like that. But that doesn't really teach us about patient experience. I think patient experience really has to be taught with the broadest brush that we can possibly do. And that can't be the wealthy side. It cannot be the side that can just afford everything. I think that if we begin kind of like go do a first principles review to say, if we truly focused on access and equity with first principles, and we handled properly the patient experience across the spectrum, then it will trickle up to those that can afford it. Why worry about doing the top end and then hoping that it will trickle down? Instead, worry about the full spectrum and let it trickle up. Do you think that would work, Ray?
It's I think I'll just say the part that you missed, because Shahid, you always ask hard questions, is the quality piece of it and the quality of the care. So I think we've done a good job in the last year for the pandemic with a singular focus across all healthcare systems in terms of improving that access. But the outcome is really the quality. And so if the quality of the care that's provided to the underserved is proven to be effective, right? I need to believe that it can trickle up, whether as we're doing remote visits, as we're doing remote patient monitoring, as we're doing more home health or the patient-centric home, and you're able to achieve that in underserved communities, where you can have multi-generational homes living in there where folks cannot self-isolate, for example, if they were COVID positive. It in fact can absolutely trickle up, because I look at it, it's almost a call to action. If we can really, work well with the community here, the overall country and the ecosystem benefits, and it does trickle up.
No, I love it. In fact, Jan, as you think about this idea of trickling up, as an engineer, when we work with whether it's websites or mobile apps, et cetera, when we design for a wide disparity of different types of audiences, it actually improves the application for everyone else. So if you can work with, for example, the blind, you're pretty sure you can work with the sighted. The inverse is not true, though. So yes. I know you've spent a lot of time in healthcare as well. So talk a little bit about this idea of, does shifting your focus on one group of people make things better for the others? That trickle up effect, as it were. And then what are some of the challenges that you see in implementing for these other communities? Often they're called marginalized communities and other things. I mean, they're just different groups of people, right? So I'm brown and Pakistani. It doesn't make me any more or less marginalized, right? It just means I'm a different kind of person, and I need personalized attention for my particular background. That's how we should see, whether it's the deaf or the blind or autistic people, et cetera. Whatever the cases are for the differentiation, tell us a little bit about how you see this from the innovator community, and does the trickle up effect really work if you focus on these smaller groups of individualized and personalized views?
Yeah, so Shahid, I mean, I spent a lot of time in the Medicare space and worked also a lot with the FAQH. I love them too. So I see there so much of the trickle up, because we started going, well, we need to go out to their homes. We need to knock on their door. We need to see what's in their pantry. And now what I'm really seeing is that starting to apply to, my family that I'm keeping at home, because I don't really want them to go into long-term care. I think they're better off at home. And can't we do things to bring services into their home instead? And I think all of that thinking really came to me from being in the community and really seeing what we were doing and the difference that it could make in people's lives that were at home. COVID certainly brought to reality the fact that we were leaving people behind here. I think we were all, I don't know, or just shocked to go, oh yeah, everyone doesn't have internet? Oh, really? That's shocking to us, but it was a reality. So I think, in now where I've sort of shifted to is looking at low vision people, and let's begin to realize the number of baby boomers that are marching into healthcare, regardless of stage and phase of life and what their social economic status is, they are dealing with low vision. So as a healthcare organizations, if we are really going to become consumer centric, and we're going to put transparency out there and say, here's the cost and here's the quality outcomes, and everyone gets the chance to see that information, then we aren't really going to not be sharing all that information with absolutely every person. And that means we have to think about the people who have internet but that are blind, or the low vision, retiree who's going, I need this in large print. I can't read what you've done. And the reality for me, having gotten to T-Base a year ago, was to call up on my EOB and say, oh, I'm calling the phone number that says I would like this as an alternate format, and waiting an hour to get someone on the phone on that phone number who said, oh, well, you have to talk to a certain person about that. And I thought, in the day when I went through being blind, the whole fact is my life is flashing before my face. How am I going to operate at that time with two small children? I've been on hold for an hour now and this isn't solved. So, what I'm really working at is bringing to healthcare the reality of a couple things. One, it's not that hard to make it accessible to everyone. And two, there are some regulations and requirements that say you're supposed to be doing this. And COVID sort of made it clear that, hey, we haven't been doing it. So we can move now to something else and really get ready to support the next COVID, God forbid, or transparency, or all the other things that are really coming to healthcare.
Yeah, those are excellent points, and that's great insight, especially making the case as it's not that hard, right? So it'd be really challenging if somehow we're talking about getting somebody to Mars, but we're not talking about that. So that's great. The other piece that you mentioned, which caught my attention, I'd love for Nabil to jump in here and talk about the fact that how do people, is it true that most of leadership within, whether it's Metro Health or even at the RAISE organization, are the leaders mostly representative of the patients that they are serving, close to representative, near representative? Like, where do you feel that is? Because and the real question there is, how does leadership truly find out what the challenges are day to day for their patients to be able to make that access and remove the disparities? Often things don't get removed in disparities land because leaders didn't know that it was a problem. They're not mean, they're not evil, they just didn't know that something needed to be solved. So how do leaders find out, Nabil?
Well, you have to have the right leaders to start with, okay? And as a physician, if you don't know your patient, good luck to really care for your patient. So if you want to be a leader in healthcare, and if you want to serve a certain community, I mean, I just said you're serving a community. You're not in a business of opening a healthcare system. You're serving a community. So you better know. I'm going to give you an example how this becomes almost intuitive if you really are in touch with your community. So going back to the COVID crisis when it first started, we were, and since we're a little bit about virtual care and telehealth in here, so I can feel free to jump into this topic as well. We have been trying for 3 to 5 years to really advance the telehealth agenda within our physician group and our health system. Good luck for me. I could not get our provider, our patient adoption, etc. Here comes the COVID crisis, a burning platform. We were less than 1% telehealth. And then we had to make a decision overnight. We're going to close the facilities, most of the outpatient facilities. How are we going to have accessibility to our patients? Understanding who our patients are. What some of our leadership jumped on to say, well, let's just get our video visit, audio visual going on very quickly. And we know we have a great informatic department, and we are an Epic shop. We should be ready. We've been using it in pilots. But this is where I stopped everybody and said, well, yeah, that's great. Well, you're making a lot of assumptions. You're making an assumption that the patient that we're serving have a means of internet access, have broadband. You're making an assumption that they have an audiovisual device. You're making an assumption that if they have an audiovisual device, they know how to download your app, sign up to your app, and navigate the system just overnight on their own. And besides, who told you that they want to show you the environment where they live or where they're taking the call from? So a lot of assumption that one wants to jump into and provide. And this is where we said, absolutely not. Yes, we will make it available, but it's got to be a patient choice. And let's make a telephone visit, which is an audio only, equally accessible as a video visit for the patients. And that made a big difference. I mean, we jumped from less than 1% of our visits being telehealth before COVID to a peak of 75% during COVID. From that 75%, 90% of those were telephonic visits, audio-only visits, and not video visits. So I can tell you that our patient population was able to adopt very quickly to the telephonic visits. I can keep on giving you concrete examples, and potentially I don't want to take the podium from my colleagues in here, but we can dive into a lot of other examples where those specific decisions that one has to make, understanding who are they serving.
Perfect. No, and Ray, I'd love for you to add on to what Nabil is saying, but maybe crystallize this a bit. Is there are there mistakes that you think leaders might be making? Kind of like what Nabil said, is that you have to don't make assumptions A, B, and C. Did you get all the assumptions right, or do you want to add some there? And maybe some other advice about how do you actually get to know the patients that you're serving? Where do you get the data from? How do you let that drive your decisions? Any advice there?
Yeah, so again, a lot of parallels between Nabil and Ultimed. But you come back to the company culture and the company leadership was your other question. So, I mean, Ultimed grew up over 50 years ago for the free East Lake Audio Clinic, and our CEO, Costley Rocha, has been with the company for 45 years, right? So we grew from a single clinic to being over 50 sites and serving 300,000 patients. So at the core of what we deliver, and our chief administrative officer always insists, right, that the care that we provide is culturally competent and aligned to what our patients are requiring. So there's a couple of interesting stories on that one. We're also an Epic shop, and we went live about a year and a half ago, and we had Epic Spanish translation, no fault of Epic, right? But people in Verona, Wisconsin probably speak different than people from East Los Angeles or Mexico or Nicaragua, et cetera, right? And so we actually had to translate all of the Spanish in my chart so that it was at a 3rd or 4th grade level, so that it was culturally appropriate, for our patients to be able to read it. Another example that we learned is, we're talking about a mobile first strategy here, and people have cell phones, and they're fairly broadly distributed. But oftentimes, many of our patients, they don't have the latest cell phone. They could be having an iPhone 6 because there was something that was provided to them, and the manufacturers don't test for it. They don't allocate for it. So as part of our digital outreach, we're doing SMS texting, and sure, it worked great on an 8 or a 10, but we had a couple 6s and even a couple 4s, which would be a possibility of somebody having, and we actually required them to test down because they had skipped over that in that area. And I think the other area is on the video and the ability to bring in translation services. There's been a lot of improvement in terms of the vendors being able to bring in those. But when we started this a year ago, if you wanted to have a multi-video window where you'd have, I'll say Dr. Shahad, because he's a physician here, and say I'm the patient, and Jan is an interpreter that we call in, so you have a full live stream, and Shahad, if you're the family member, that ability didn't really exist a year ago in there, and then to Dr. Shahad's point as well, when you look at the adoption of a telephonic versus a televideo, I mean, I think we're still learning, the digital desert that is out there in rural and urban areas is true. There's legislation that is being reviewed in terms of the Life America Act for health infrastructure, and broadband is being reviewed now, as well as expansion of broadband across the nation, which will be ubiquitous. And then if you lay over one other piece of it, which is the social vulnerability index, which actually tells you what are the social determinant aspects of a particular zip code, and you tailor your care delivery model so that it really addresses many of those needs. These are things we have to consider as we develop our health plans to reach out into the community and to be really effective.
Nice. Yeah. So if you expand on that, Jan, a bit, I'd like to take us maybe from the idea of what we have been looking at to tell us, whether or not we're understanding what our patients need, to knowing whether we actually gave them what they needed. And so this is something you could generally do fairly well on the purely technical side, and that is, if you made something in Braille, you're going to know how many people access the Braille components, right? So you can check and see, that N number of people did access it, or the audio version versus the visual version. So there are ways of measuring whether or not you're truly accessible. Can you talk about some of those techniques? Like, how do you know that you're actually properly accounting for the accessibility that you need to provide to your patients?
Very great question. What we really find is that healthcare organizations generally say, oh, we don't have that many blind people. So it's like, oh, how do you know how many blind people do you have? When was the last time you asked? Is it on an HRA? Well, how many people answered that? You know, that's really the typical kind of answer. So we just start by saying, you know, there are some requirements to make sure that you have the information available. And usually the answer then is, well, we meet the ADA requirements. Well, guess what? There are no ADA digital requirements. When the ADA was developed and even when it was modified, there were still no digital requirements around that. So Section 508 is what made the digital requirements, and there are guidelines for how to meet Section 508 in the digital world. So what we just learned in COVID is that really a lot of websites of healthcare, especially all the attachments, which might be forms that say, enter your ID number here, those were not readable on the computer. So while that was attached to a website and maybe the website kind of worked, but when you got down to a person really needing to enter their information, it was not understandable to them because it wasn't accessible. So that just hearing a lot of the, oh, we need ADA, well, do you know what that means? And when we walk down that road, all of a sudden they go, oh my gosh, we have no idea. And so very quickly, we are seeing hospitals, provider groups, you know, the healthcare big organizations that we normally think of as payers, all of them are going, oh, we have work to do here. We have work to do here. So this is really, you know, Braille as an example is something that a person will specifically request. So that isn't available in a digital format, but they have the option to say, oh, would you like this in an alternate format as a drop down? So yes, I'm choosing Braille. That means now we're going to produce that and ship that to you to your home. I was just recently working with one of the IT directors of a very large provider organization, and he said, I've been in communications for 15 years, and I have, for the first time ever, seen a Braille document. Lots of people have asked for one. I've just never touched one, and it's amazing to see what it's like. So it just really, to your point of who's in leadership, what do we really know and understand about these subgroups of people that we're leaving behind? And when we say accessibility, how large are we really thinking? So we're seeing a lot of progress, a lot of interest, a lot of, oh, we need to do something here. You know, the EOB needs to be put up on that website and it needs to be accessible so a reader can get it, or that person needs it in large print every time. So I think of this from the CAHPS sort of perspective. So HEDIS and the CAHPS metrics are now equal clinic and member satisfaction. And when you think of that, you sort of go, okay, I've got to really be not asking this person over and over and communicating with them one way this time, and next time I make them tell me again, and you know, because these are going to be our reflections and very much impacting our bottom line. So that's what we're seeing and learning.
Yeah, no, I love that particular advice, which is just in case there's no business model to do the right thing, which is make things accessible, it can impact your quality score. So if you want to take your budget and say, I'm going to do accessibility, make things more accessible because it will help my HEDIS scores or HCAHPS scores, awesome, right? That's another reason to do it. That's actually perfect advice. Now, leading from that advice, I'd just like for you, for Nabil, you and Ray to comment on the following as we finish up over the next few minutes, and then open up for questions to our audience. How do we know which organizations are truly making a difference to the underserved, to health equity, reducing disparities? Everybody likes to talk about it, but let's say you do have leadership. They love the idea that they're going to do this. What are some of the techniques? What are some of the ways, Nabil, that you can actually institute KPIs, measures? How do you know that you're actually accomplishing a reduction of disparities that you're hoping to do?
Absolutely. I'm going to give you a concrete example. About 2 years ago, we decided we're going to tackle informal age. So Metro Health has been in the community for 183 years. And we've been serving the underserved for all these years. But we decided that we need an organized way to look at the social determinant of health and the needs of our patient. So actually we can measure, we can see the outcome, so we can decide how to allocate resources. And to do that, we became purposeful. we created an institute under our population health that is dedicated, that is just the sole work for that institute is to attend to the social determinant of health for our patients. So we screen as many of our patients as we can. We have a goal to screen if 100% those that want to be screened. I say 100% those who want to be screened, and we are 1/3 the way there. And we started this about a year and a half ago. Once we screen, we put and invested. Our organization invested in a electronic referral system. And when we were selecting, and it was under my leadership guidance, that as we're trying to select an electronic referral system, we want to make sure that we understand the data and how that loop is being closed as we're making referral to a community-based organization. Just making a referral is one thing, but understanding what the outcome of that referral has benefit the individual is something else. Then as you do this, you understand what those interventions, what those referrals are, and you're able to track them and capture that data in a discrete way where you can measure. Then you can do study, and you can publish, and you can advocate. Once you advocate, you can get the money, and you can then invest more in what you're doing, and you're not just serving yourself, but actually you're serving the other organization and your peer as well.
That's a great example. Ray, could you elaborate on how do you guys prove that you're making a difference in the way that you want to?
Yeah, so we also have an Institute for Health Equity under our Chief Operating Officer, Dr. Efrain Montes, that really focuses in on the SDOH aspects in our outreach, and we look at the data and mine the data around there. But the other things that we also look at is in terms of our quality panels. Again, the patient population we serve are in many of these SVI, socially vulnerability index areas. So we're looking at the quality of the care, how we're managing specific disease states with specific quality measures as well, because we live it every day in terms of serving our patients. And are we moving into the 75th to the 80th percentile? So we get that real-time data. And I think the other thing that we have the opportunity of, as well as we map into the community and through COVID-19 vaccination, we've been here for a long time, for over 50 years. So we're known and trusted in the community. And so as we've administered thousands and thousands of COVID-19 vaccinations, it continually allows us to reconnect, with the community as that trusted source. And also brings in other members that may not be coming to AltaMed to become familiar with us. Again, culturally, linguistically appropriate, in Spanish, understood, explained, demystified, so that it creates, that bonding with the organization. And then we're able to then leverage, other opportunities, other areas to keep them and improve their health overall.
Got it. Excellent. So we've got a couple more minutes before we're going to open it up for full Q&A. So what I'd like to do is to have Nabil and Ray talk a little bit about what would you say are a couple of the biggest surprises that you've learned over the last year that maybe you wouldn't have known had COVID not come along, but you're taking away with you into the future. It could be around health disparities, or just in general. We just love to hear a lot of the folks that we talk to at HealthIMPACT. We just like to say, well, what surprised you the most over the last year during COVID that you're definitely going to take forward with you? And then we'll have Jan kind of conclude to see what is she hearing from other organizations, because they serve multiple hospitals, to finish us off taking in. So a couple minutes, Nabil, any surprises, big learnings?
Well, yeah, very big. Again, I thought that the major obstacle is broadband access, etc., which does exist with our patient population, but it goes way beyond this. Training, education, being able to communicate with, just like Ray said, just because you have Spanish doesn't mean that you are able to communicate with your patient intended. You got to be very targeted, very specific. Just like Jen said, there is specific population that also can be a group that is very well forgotten. We always try to solve to the 80-20, but what happens to the 20?
Right.
Okay, and it's the 20 that drags everything down if you don't pay attention to it. We go back, I'm taking you full circle to where you started.
Yeah.
Yeah, I would just, again, I would say the broadband, it's a continuing challenge that has to be addressed. And I think we'll get there sometime soon around it. But again, it really is to the training and the adoption. It's a provider change, right, in terms of how they will provide the care, how we change the room, and does it work or not work? Have we provided the right level of support for them, for the providers to make it easy? But then on the other side, again, it's really educating our patients. We only wait so long before we click out of a page or we drop a call around there. And that's a very quick time. And that ability to shift from a televideo, if it's not engaging due to bad coverage, noise in the background, and many items that can be just distracting, and a patient in there, we have to have that ability to switch the telephonic, and just continue, that care encounter with the patient I think is so important. And that nimbleness and that flexibility is one thing that we've learned and we continue to try to work on. But it's a lot of training and understanding, demystifying it, making it easy. I'd like to say easy as Amazon, right? And we're not there in terms of that capacity of the delivery.
Yeah, I've heard that physicians and nurses and providers are also human. They need training, they need time to adapt, et cetera, in addition to the patient. So we often talk about the patient side, but what has pleasantly surprised me is how flexible our physicians and nurses especially have been on the front line, right? I mean, they've been adapting very, very quickly, and we've always known they've been adaptive. But when we've always been putting technology...
We're not that adaptive. We need a burning platform. I mean, yes. I just told you, if there was no burning platform, this is the moment to redefine the way we do care delivery, because it's the unfortunate but fortunate consequence of the COVID pandemic is that created that burning platform to make a change. Yeah. So
Yeah, I agree. It's been that singular focus across all health systems for the change, and we had numbers 60, 70% similar to Metro Health, but I think that folks will kind of drift back, right, to being a lower adoption and the more traditional care models, and the question looking forward, right, is how do we keep that energy going, right? How do we not have 20 competing projects in terms of care delivery that now dilutes all the good work that we've done, and we have continued momentum.
Yeah, no, I love it. And Jan, I'll let you take the last couple of words here. But where I was going with the idea of flexibility is, now that we've seen what is possible because of the burning platform, I think, Nabil, you're 100% right. Now that we've seen the flexibility, going forward, we shouldn't be able to say, well, no, that change is not possible. Well, wait a minute, you just did it last year because you had a reason to do so. Are you saying now that our new initiative, that you have no reason to do this? That's where I'm hoping. And this has happened, because my wife is a teacher. Lots of teachers have gone through the same thing. For years, they used to say, there's no way students would do this, or teachers would do this, or parents would do this. All of a sudden, we saw that people would do it. Now the question is, are we going to have very, very short memories and forget that we did all this? Or will we be able to take it forward? That's going to be something that the audience can definitely talk about as well. So what are you seeing, Jan, if you talk a little bit about some observations from your customers, anything you're surprised about?
Yeah, I just think my years, I love you guys saying, we haven't really been that flexible all these years in healthcare. And I go, sometimes I think we've been talking about the same thing for 25 years. Now we're actually doing something. And I think we have moved the needle little by little over the years. But trust is a really big thing. And both Ray and Nabil have, spoken to that. Trust from the patient perspective. And in order to gain that and keep it means I hear you, I understand you, and I'm doing something about it. And that's what we sort of didn't do. We went, oh, we're lumping everyone together and here's what we're doing. We hope that works for you. What I'm seeing a lot in organizations now is what I saw when we all started focusing on the quality metrics. We suddenly looked up and said, hey, It's everyone's responsibility in the organization. You know, whether you're in customer service or whether you've got to be focused on quality, because, oh, look, we assigned all these male doctors to these female patients, and we found out culturally they were never going to go, but that impacted our quality metric, and we thought we were doing all the right thing. So what we're doing, and what I'm really seeing now, is sort of that same thing happening, an environment and a culture of accessibility within organizations that says everybody has to think about this. And if you're making a document and you're writing a letter and you're getting ready to send that out, have you thought about the people who have low vision? How are they seeing that? Do you know who those people are? Hey, oh, you're working on renewing your website? Well, hey, have you had an audit to make sure that every piece and part is there? And so it's really becoming global within every organization.
No, I love it. And, you know, big thanks to Jan, Ray, Nabil. We're opening up for questions, ask away. And we've got about maybe 8 to 10 minutes left of Q&A. So please ask away. Thanks a lot, everyone. All right, welcome back. So we're going to be taking Nick's question first. And Nabil, you've already commented on this, but I'd love to maybe expand on that a little bit. And so Nick's question is, how soon do we expect to be able to data mine telehealth visits from 2020 and plug them into population health model segments? And Nabil, you very astutely said, hey, the data from last year may not be exactly representative about what's going to happen in the future. And I'd love to maybe concentrate on that. Is what do we see in the data from last year that maybe we should be questioning a bit and maybe not using for predictive models and things like that going forward? Any obvious ones other than the fact that, you know, telehealth may come down? Are there other kinds of data sets that we should be aware of and be wary of?
Well, yeah, you just said that the numbers were artificially high. So even from the number is the appropriateness of the visits. Perhaps some visits were not fully appropriate to be telehealth. And that we're not going to be able to tell. Only with time and when the pendulum swings. So the pendulum swung to an extreme with the pandemic, and that's probably as extreme as it is. Until it settles down, and hopefully around the 25 to 30% of the visits. Once you have that stability, only then you can make any conclusion about what is appropriate, what's not appropriate, what have we learned. Otherwise, it is purely artificial. I just don't know how to interpret data from last year. 2021 is probably a little bit different.
Got it. So Jan and Ray, if you hit the, there's a video and audio button in the top left corner of your browser. Just hit that and that'll bring you online. Great. Any thoughts? We have a couple of minutes for this last question. So Ray, do you have any extensions on what Nabil just mentioned about what data should we trust and maybe not trust going forward because of
Yeah, I mean, it's interesting, like from a billing perspective, right? I think the code is a G0071 is the one that many folks use. And, you know, in Medicare and Medicaid, the reimbursement models are different. So for instance, in Medicare, you cannot bill a nurse visit. That's through a televideo type of opportunity, right? And so I think time will tell. We'll have to learn more around there. I understood that the feds were looking at a 2-year study in terms of the effectiveness of the telehealth offering, the televideo and telephonic. And I guess we're about 1.5 years through that, right? In terms of where they will land. So I think that'll be telling, right? In terms of how the feds will look at the data, which may also drive reimbursement and other areas in terms of the outcome. But we do need to keep an eye again on the quality, right? I think having the access and extended access is so important so that we don't, you know, purposely lead anybody behind, but it will shift, right, the way that things are going to be happening.
Got it. Great. In the last 90 seconds, Jan, anything that we took for granted during the pandemic, even in terms of accessibility, et cetera, that maybe we should be rethinking as we go forward that you can think
Well, there was certainly a lot of public health information that folks with low vision or blindness were not able to access. So they also didn't necessarily have transportation to even get groceries and things like that, which we would not think about. We might have all been ordering online, but if they couldn't order their food online, they also couldn't get out to the store. The COVID clinics, that brought some new revelations that they didn't have the public information to know where to go for those. So a lot of information came out, a lot of reality about, again, what populations are we leaving behind? So just continue to change the world.
Yeah, that's fantastic. Well, Grant, thank you very, very much for all three of you joining us here during this session. Ray, thank you very much. Jan, Nabil, if you guys have any questions, and especially for Jan, because she wants to talk to as many of you as possible to help out in this accessibility area. Hopefully Ray and Nabil will take her up on her offer as well, and think about how do you actually look at deaf, blind, and other community members as the good, like Neil said in the chat, these are hard populations to work with. Maybe working with the hard populations, as Michael Porter wrote, is the right way to go for all of us here. So with that, thank you so much for joining us live here, and to the audience, please join us in our next innovation session that starts in about 30 seconds. Thank you. Bye all.
Thanks.